Welcome, everyone. My name is Brianna Gregory, pharmacist with Physicians Preference Pharmacy in Katy, Texas, and I'm excited to talk with you guys about low dose naltrexone. So, for those of you that are familiar with low dose naltrexone, you'll know that truly it has been an option to treat many very difficult to treat conditions or treatment resistant conditions. And so I want to give you a few options to incorporate the low dose naltrexone into your practice and familiarize yourself a little bit more with some of the options that we have going forward and how to incorporate it for some of those hard to treat, stubborn conditions that you may bump up against in your practice with these patients. So let's go ahead and get started. So first, for us to be able to understand what low dose naltrexone is, we first need to understand what naltrexone itself is. So naltrexone is an FDA-approved drug for the treatment of alcohol dependence or dependence of opiate drugs, such as heroin, morphine, also oxycodone. These are just a couple of examples that generally patients are familiar with, and of course, providers are familiar with. So if you're prescribing naltrexone, generally we're talking about a typical dosing of somewhere between 50 milligrams up to 300 milligrams daily. And therefore, low dose naltrexone, of course, is a much lower dose than the commercially available naltrexone itself. Low dose naltrexone currently, because it is a compounded product only, has no current FDA approval, but it has been proven to be beneficial in many conditions. Last time I checked, probably somewhere upward of 75 plus conditions when used off-label, of course, because we are using a much lower dose of a commercially available product. And really the uses here range from anything applying to skin disorders, even to certain types of malignancies and cancers. And really that's some of the most two polar opposites that I can think of in describing the vast and broad application of low dose naltrexone. So a low dose is considered really anything less than 25 milligrams and is substantially lower than standard dose than the commercially available naltrexone. The same active ingredient in LDN, which is naltrexone, of course, exerts very different pharmacodynamics from our higher dose of naltrexone. So I put an example in here of what the titration looks like, because generally low dose naltrexone would be used for something like an autoimmune condition. That's probably one of its most common applications. And so just to kind of get a taste for what the dosing looks like here and how we work it up, I provided this example. So for someone who has an autoimmune condition, let's say something like Hashimoto's, perhaps Sjogren, psoriasis, something like that, their titration process is going to be somewhere around probably 3 to 4 weeks for them to reach that max dose. And the way that this looks is that you'll start out with generally 1.5 milligram capsule. You'll do one of those every day at bedtime for week 1. And then every 7 to 10 days, you usually work up another capsule. And so for the patient to reach their final intended or anticipated dose, probably takes somewhere between 3 and 4 weeks for them to reach that final dose. And then each week, they just bump up the number of capsules until they reach about 3 capsules or so, at a total dose of 4.5 milligrams. And then at that point, considering if they're tolerating it okay, we can go ahead and consolidate it down just into 1 capsule every day. Okay, so let's really dive into how LDN works. As far as its mechanism of action goes, it does serve as an antagonist, a reversible antagonist for both opiate and endorphin receptors in the body, as well as many immune cells. So as it hits on these opiate receptors, it's going to hit on primarily mu, but also kappa and delta binding sites, and then it creates a positive feedback system. So when it does this, it increases endogenous opioid or endorphin release, which then leads to a modulation of immune response. So it does this in a couple of ways. First, it regulates lymphocyte responses, downregulates cytokine production, as well as reducing mast cell activity. Endorphins then, as they're increased, produce analgesia, promote healing processes, reduce inflammation, as well as inhibits cell growth. So I did point out that LDN has the highest affinity for mu receptors. The mu receptors, the reason this is important is that the mu receptors are responsible for modulating analgesia, symptoms of depression, euphoria, as well as physical dependence. And we also see that LDN inhibits toll-like receptors, which are responsible for decreasing the release of certain pro-inflammatory cytokines, for example, TNF, IL-6, IL-12, inhibits T lymphocyte proliferation, as well as providing a reduction in the inflammation and also the potential downregulation of oncogenes, which is where it plays into being used to treat certain malignancies. Also, I'll point out that the toll-like receptors can be responsible for either upregulating or downregulating inflammation. And depending on where that patient is in the treatment process, or depending on what condition we're actually treating, we want to have some upregulation and downregulation, but sometimes we want the upregulation to be favored, sometimes we want the downregulation to be favored. And that's why it's so important to have this toll-like receptor modulation that really provides a healthy balance. So, for example, those TLRs are often found in skin and other tissues too, but there is a high concentration of them in the skin, which is where we see applications like psoriasis, for example. Interleukin 6 is present highly in the central nervous system, which is where we get some of our indications for our neuropathologic conditions. IL-6 does participate in neurogenesis, so really it influences both neurons and the glial cells, and that's where the implication for LDN comes in for those neuro conditions. It also promotes mucosal and tissue healing, provides neuroprotection through glial cell activation, like I mentioned in the CNS, promotes T cells and natural killer cells, and also provides upregulation of genes responsible for apoptosis. All right, so here's a chart that illustrates the mechanism of action of LDN, and it does it in various ways. One of the first examples is that it does increase endogenous enkephalin and endorphins. This is how it provides enhancement of the immune system, as well as stabilization of the immune system. Of course, we see the inhibition of pro-inflammatory cytokines, which is how it supports the the inflammatory reaction, either up or down regulating it, or kind of helping it meet somewhere there in the middle to really provide a healthy balance of immune reaction, not tipping anyone to one side of the scale versus the other. And we also get promotion of DNA synthesis and healing and repair of mucosal tissue, as well as regulation of T regulatory cells, and then production of interleukin 10. So the regulatory T cells, the reason that that's important is that they are responsible for suppressing the immune response, thereby maintaining essentially homeostasis within the body, and then providing self-tolerance for the patient. Okay, so certainly this list is not exhaustive. Here we'll talk about some of the conditions that are currently being treated with LDN. And like I mentioned earlier, the last time I checked, there were probably something like over 75 different conditions, if not more, that LDN is being applied to. But here's just a quick review of that. So dermatologically speaking is probably one of the biggest applications of LDN. We see it used in alopecia, atopic dermatitis, eczema, and then probably psoriasis is the biggest one in this column. Again, that's partially because it is a genetically linked condition, and we can also really modulate the immune system by helping knock down inflammation in that psoriatic process. It does have endocrine implications, so Addison's, Cushing's, type 1 diabetes. Probably the biggest one in this column is going to be Hashimoto's, again, helping to knock down inflammation and really support healthy immunity there. So gastrointestinal applications, Crohn's disease, ulcerative colitis, which we'll get a little bit more into here in a few minutes. Neurological applications like ALS, MS, as well as Parkinson's, and then also restless leg syndrome. Rheumatic situations, lupus is another big one. Sjogren's is another big one. Psychiatric applications such as anxiety, generalized anxiety disorder, as well as depression, even PTSD. And then, like we talked about, the regulation or downregulation of oncogenes is where it plays into malignancy. Probably the biggest ones here in this column are bladder, ovarian, as well as uterine. So I think it's important to talk about some of the opportunities for low-dose naltrexone, just so that you can get a good idea that if you're not already implementing LDN into your practice, that it's a very easy addition with so many different implications for a wide variety of patients. If we look at these statistics, over 75 million people in the US alone suffer from either an autoimmune condition and or some sort of chronic pain. There's currently more than 100 different autoimmune diseases that people are struggling with and require treatment. Sometimes they really exhausted the end of their rope and they're looking for that last option, which for a lot of people, honestly, that's how providers will find out about LDN, because they're doing research for these patients that are at the end of their rope and they're trying to find sort of a last resort option and stumble upon just how useful LDN is. We also have a significantly increasing aging patient population with increase in baby boomers and patients that are kind of reaching that older age bracket. We do see some decreased immune systems, right? Which means that the autoimmune conditions or chronic pain that these people are dealing with really leaves a wide window of opportunity for us to go in and address those by knocking down inflammation, but also addressing the root causes that are causing some of these or exacerbating these autoimmune processes, or even chronic pain, chronic inflammation. That's a big complaint here in the United States for our patient population. And then for those of you that this is in your wheelhouse, there are clinical indications for expanding the use of LDN in both pediatrics as well as pets. So just to give you a side-by-side here of naltrexone with low-dose naltrexone, like we talked about earlier, naltrexone is used for alcohol and drug dependence and helping bring someone off of that or wean them off that dependence, whereas low-dose naltrexone has more of an implication for anti-inflammation, autoimmune conditions, pruritus, as well as malignancies. Typical dosing of naltrexone, of course, is much higher. LDN is somewhere, when someone says low-dose naltrexone, it's very much implied that that range is somewhere between 0.5 milligram to 6 milligrams, but really, as far as the common expectation goes, it's usually between 1.5 and 4.5. So, I've seen people on 0.5 milligram, I've seen people on 6, but generally speaking, LDN means a titration from 1.5 milligrams up to 4.5 milligrams daily. We did say that naltrexone does not require a titration, whereas low-dose naltrexone, of course, does require that titration, which is just to ensure that the patient is tolerating it okay, that they're not experiencing too many side effects. And although we will get into the side effects here in a moment, if they do experience any side effects, then it's easier for them to, I guess, tolerate that with a titration option as opposed to just starting on their max dose. The age for LDN it's been shown through the literature that we've used it in children over 3 years of age, whereas naltrexone doesn't establish that. And then as far as the side effects go, hepatocellular injury, so not just liver, but also renal function must be assessed because of any potential side effects with naltrexone, especially because it does come in high doses. And then your generic oral medication side effects, such as headache, as well as nausea and vomiting. For low-dose naltrexone, the side effects, if any, experience are quite rare. And the most common ones that I've had reported to me are either nausea, so some gastrointestinal discomfort, accompanied with nausea, and then sometimes insomnia, which again, we'll talk about that a little bit further, but it appears to be transient, going away after somewhere between a few days maybe at the max of a week. So if they are having trouble sleeping, there's options that we can do to kind of titrate back, and then re-challenge, if you will, and then those side effects typically tend to go away. Okay, so I want to bring up first an open label study looking at psoriasis. You'll note that if you try and look into the literature for low dose naltrexone versus naltrexone, which is the commercially available product, that you'll find a lot of literature on LDN, but that primarily it will be anecdotal. So we're really looking at a series of open label studies, or we're looking at case studies which have shown significant improvement. But I think that's one of the reasons why LDN isn't as probably widely recognized as it should be, is because we have a lot of these smaller studies providing the results instead of an FDA-backed study. So in this open label study looking at psoriatic patients, we had 15 patients, 13 were female, 2 were male. I think probably the reason that the sex of the patient population or participant population is a little bit skewed there, so to speak, is that we're looking at an autoimmune driven process, and generally females identify with autoimmune conditions more frequently than men do. So that's my thought process there. So all these participants, all 15, had previously used at least one type of topical treatment with nothing more than a partial response. 5 of them had actually completely failed the response, failed to have any sort of response to one or more topical treatments. Some of them had partial resolution, but really no one ever achieved disease remission of these participants, study participants. So they were pulling these psoriasis patients in to see if a trial of LDN would help them. And what they found is that the average age of the patients that were enrolled were about 57 years old, and that they had each had psoriasis for about 16 years. They each got the highest dose of 4.5 milligrams of LDN, and they took that once daily. And 2 of the patients decided to self-discontinue just due to side effects, which were reported as insomnia and diarrhea in this case. The symptom improvement was measured by a self-assessed Likert scale, and so the patients were reporting how well they responded to the treatment. 53% showed that they had a marked improvement in their psoriasis lesions, and one participant that stood out actually showed an 85% decrease in the total body surface area that was affected by the psoriasis. The clinical improvement was measured with a visual analog scale showing that the severity of the lesions and the cracking of the plaques and all of that actually improved by about 80%. And then for those that had joint-related psoriatic arthritic symptoms, that over those joint areas, the global skin appearance was improved. Total body surface area affected decreased, and that also the range of motion within those joints was improved as well with the dosing regimen of LDN. And then here's a picture, before and after picture, following the study that I just explained after 2 months. That study ran for 2 months of the oral 4.5 milligram low dose naltrexone. So you can see it's pretty significant improvement here. You know, also remember that the skin is a detox organ. And although psoriasis is genetically linked, you know, we can really help these patients put out the fire by some of these inflammatory and autoimmune driven processes by addressing underlying issues. So even though it does manifest itself on the skin, generally, especially with things like psoriasis, there's something else going on. And we find that a lot of times that the inflammation starts like somewhere in the gut and then works its way out. So really, it's just a good reminder to remember that let's work from the inside out with the patient. Giving them oral LDN in this case is certainly helpful, again, because we're working from the inside out, but we also have other dosage forms, which we'll talk about, including topical, that can be applied directly to the skin for patients who have an autoimmune process which manifests itself on the skin, but may not actually be starting there. So looking at an open label study about Crohn's disease. There were 17 patients with active Crohn's disease in this study, and the severity measured of Crohn's disease comes through a Crohn's Disease Activity Index, the CDAI, and it breaks it down into whether someone the disease severity, which is associated with the symptoms that the person is experiencing. So I put there that the activity index ranging from 220 to 450 is basically showing that there's some sort of moderate disease activity, and then with a reduction in those points, there's some symptom resolution. The disease activity decreases, and the patients start to feel better. So what they saw is that with the treatment of 4.5 milligrams of LDN daily for 3 months, 89% of the participants responded to a treatment with a 70-point reduction in those associated side effects, symptoms associated with Crohn's disease, and helped decrease their moderate disease activity to a lesser severe type of disease activity. So some of the symptoms that CDAI is looking at would be things like diarrhea, fever, if they're experiencing rapid weight loss or intestinal obstruction, sometimes abdominal pain, anemia, things like that. So again, we saw quite a good response to the treatment of LDN, and also 67 of those people did achieve disease remission. So it's important to point out some other conditions that LDN can potentially be used for. Some of these you may not all see in your practice, but it's important to show, again, just to illustrate the wide array of applications we have for LDN, and also to point out that some of these are very difficult to treat conditions. So HIV, ALS, Lyme, fibromyalgia. For HIV, at least 6 months into treatment, we can see an increase in CD4 counts, which helps to stabilize the immunity there. For ALS, LDN has anti-nociceptive and, of course, anti-inflammatory effects. It also may help decrease fatigue, pain, spasticity, as well as depressive symptoms, which often can accompany the progression of ALS. And then Lyme, I think in a lot of cases, depending on which provider you're talking to, but I've heard several providers lecture at conferences around the country that specialize in Lyme, where essentially Lyme and LDN go hand in hand. You don't really do one without the other. For many people, it serves as a staple of treatment. All of their Lyme patients go on LDN, and this is because it really helps to modulate the immune system, but also to restore that homeostasis that a Lyme patient generally has lost control over. One of the ways it does this is it helps to rebalance Th1 and Th2 activity. And this is actually specifically important in Lyme disease because, of course, we know that Lyme is a tick-borne bacteria. And so for the most favorable outcome, the timing is more crucial when we have Th1 secretion versus when we have Th2 secretion. Of course, as with any inflammatory process, any condition that we want inflammatory mediators to come to the site of action, the timing there is still crucial. So for something like Lyme disease, we want an earlier secretion of Th1 as it's pro-inflammatory, and then a later secretion of Th2, which is more of a calming of the inflammatory process. So we really want to be cognizant of when that activity is kicking in, because it's beneficial in helping to calm out these flares that are associated with Lyme disease. And then fibromyalgia, there's been a study showing that there was at least a 15% reduction in pain with an 18% overall reduction in symptoms. So just to include a couple pictures for you, here's some improvement of psoriasis patients in studies. It's fairly significant, especially when you look at the cracking of plaques, open skin, that really could just lead to higher risk of bacterial infections getting introduced into these areas. Ulcerative colitis as well. So we have before and after of LDN. You can see on the left-hand side that prior to LDN treatment, there's a fairly purulent appearance here, and then post LDN treatment, it's significantly cleared up. Also dermatitis. So for atopic dermatitis, that's a pretty common usage for LDN. Across the top, this is before and after, and then across the bottom, this is before and after. And you can see that there's a significant decrease in the amount of redness, inflamed spots prior as opposed to treatment following with LDN. And generally, when we're looking at these pictures, we're thinking of 4.5 milligram treatments. Somewhere around 3 months or so is generally when we start to really be able to significantly see the marked differences of treatment. So let's talk a little bit about the side effects associated with low-dose naltrexone. It's important to point out that many patients who start LDN do not experience any side effects at all. And for those that do, generally, their side effects are not severe. Also important to notice that symptoms may worsen before they improve. So honestly, I think that this is a good indicator that the LDN is probably working. Some of these transient symptoms that can worsen, if you think of the patient population that we're treating, take a autoimmune patient, for example, they probably already have a lot of malaise going on. And so when they first start LDN, it can probably bring some of those things out and exacerbate some of those symptoms. So they could experience increased fatigue or nausea, even the onset of apparent flu-like symptoms, potentially sleep disturbances. And I mentioned this prior, but that's probably one of the most common side effects that I hear about associated with LDN. And I think part of that is because LDN is generally dosed at bedtime or in the evening. And this is likely because of the increase of endorphin release. And LDN is really hitting on those endorphin receptors. And that's why those side effects come to be anyway. And when that's dosed in the evening time, patients may report some sort of a headache or even insomnia. And then I put vivid dreams there because sometimes that can be associated or be promoting the insomnia. So maybe not so much just disrupted sleep, but if they do experience a disruption in sleep, it could be because they're waking up from a vivid dream. And again, the most common side effect that I've had reported is probably gastrointestinal or abdominal pain, but usually some sort of nausea, and then followed up by the insomnia. So if we have those side effects, we have a couple techniques of how we can still have this patient stay on LDN, be successful, but decrease their side effects. And one of those things that we can do is we can instruct them that instead of taking the LDN at bedtime, that they can actually move the dose up earlier in the day by about an hour at a time until they kind of find that sweet spot where they don't experience the insomnia. Sometimes if, they are experiencing side effects and they take it prior to bedtime, they may not actually be aware of those side effects because they're asleep. And that's one of the reasons that we do choose to dose it at night. So it doesn't have to be dosed at night. I do have some patients that dose it in the morning, but it's a good baseline to start dosing in the evening and then work with meeting their side effects, where they're at, if that's something that we have to deal with once we start titrating the patient up. Another option, if the patient is experiencing side effects, to try reducing the dose by about 50% for about 7 to 10 days before increasing it back up again and starting to titrate up again. Again, that's a big part of the significance of the titration process to begin with, is to make sure that they can handle any side effects that may be associated. All right, so as far as interactions go, low-dose naltrexone is compatible with most other therapies, actually. But low-dose naltrexone may compete with or even alter the effectiveness of certain opiate painkillers. If you think about what naltrexone is used for, it makes sense that there is that competitive antagonism. Also, if the patient is on tramadol, this is due to binding sites. We don't want to give them low-dose naltrexone if they're taking something like an opiate, because of course they're going to compete for each other, and either one of those, the LDN or the opiate, is going to get kicked off the receptor site, or they're going to cancel each other out, or you're going to have an increased concentration of one versus the other, and really it just becomes null and void. So these are all questions that need to be asked, which need to be considered when starting your patient on LDN and initiating that therapy. So good question to start out with asking is the patient currently on opioid medications or on tramadol? If so, is it something that is indicated for ongoing treatment, or is it something that they're being weaned off of? Also, we need to have caution in liver and kidney. If they have a history of liver or kidney dysfunction, we do need to be aware of that, because this mainly comes from naltrexone itself. So when patients start on naltrexone in the full doses, it's been shown to transiently increase liver enzymes. And so patients that are being prescribed the commercially available naltrexone for addiction or weaning them off of that, they actually have to have liver function tests performed before initiating therapy at all. And just to be clear, those tests are not necessary when initiating LDN therapy, but that's where that comes from, because the active ingredient is still the same in naltrexone or low dose naltrexone, but because the dose is significantly lower, we don't have to test for it, but we still remain cautionary about that, and just weigh the risks versus the benefits. And if it's something that's very serious, if someone's been in renal failure or liver failure, had acute hepatitis, then we need to be very cognizant of that and make sure that they have a full history taken and a thorough examination by their provider. And then also, if there's current opioid or alcohol ingestion, then we need to make sure that we stay away from LDN. Again, there's a competitive mechanism happening there. Okay, so the formulation options that we offer at Physician's Preference Pharmacy come in 3 different options. So we have oral capsules, sublingual tablets, as well as topical cream. Again, your oral option is going to be the most common option when it comes to low-dose naltrexone. And this is because we do get systemic absorption with that. And also for certain conditions, say like Crohn's disease or ulcerative colitis, in compounding, we love to have our medications delivered to the site of action directly whenever possible. So if we can have that patient swallow an oral capsule, we know that the low-dose naltrexone is getting delivered straight to the site of action that needs to be addressed, and then they're still getting systemic absorption, healing of the tissue locally, and again, we're delivering it to exactly where we want to go, so we use that to our benefit. Very rarely, some patients experience gastrointestinal side effects such as nausea, like we talked about, as well as diarrhea or even constipation. Very rare, but if that happens, then we really can circumvent the gut altogether with changing our route of administration, and that's when we can use a sublingual tablet as opposed to an oral capsule. So that provides another option. And then we can also use a topical cream. So for our eczema patients, our psoriasis patients, where we want to address generally the pruritus that's associated with some of these inflammatory conditions, we can use a topical cream to go in there and again apply it directly to the affected area. And we can combine multiple dosage forms. So it's not uncommon to see someone go through the typical titration of low-dose naltrexone, starting at that 1.5 milligram capsule that we talked about, working up to somewhere around 4.5 milligrams. And in the interim, as well as throughout the duration of the therapy, they can also apply a topical cream in addition. So I really like the example of a psoriasis patient, because I think a lot of times, if you look at what a psoriasis patient can typically look like, they may not be the healthiest of people. They may be semi-overweight or even obese. Of course, this isn't exclusive, but it seems that that's pretty common, and it brings our attention to also wanting to heal the gut and look inside and look at the root cause and treat from the inside out. So if we go in and we clean up their gut, we clean up their diet, we like to give them at least a good 3 months of committing to some sort of food elimination and trying to heal that gut tissue. By cleaning up the gut, we can decrease the inflammation. And while we're doing that, we can go in and treat them with oral LDN. But in the meantime, where their body is still detoxing and getting rid of all of those inflammatory mediators and also detoxing out, we can go in with a topical formulation like a cream, which gets applied directly to the skin where that inflammation is being manifested, and help to decrease that itching that's spurred on by the inflammation, which initially is a problem within the gut generally. So again, looking at all the different aspects of where this is stemming from, but we can combine formulation options if necessary. And then I did want to provide you guys with some resources here that I think are very credible. The first one is a website to ldnresearchtrust.org, which is an excellent organization that provides unbiased and comprehensive information about low-dose naltrexone, how low-dose naltrexone came to be. There's a lot of literature links on there. It has links to patient studies and case studies and patient testimonials. There's also a section for pharmacists as well as providers, and it's a really good comprehensive tool to get some more information about low-dose naltrexone and also see the wide variety of applications that it can be used for in your practice, where you may be bumping up against some medication resistance issues, and LDN could be a good option to come in and treat those. And then also the 2020 LDN Research Trust member badge I have here because Physician's Preference Pharmacy is an LDN Research Trust member. But I wanted to add that in because when you go to the LDN Research Trust website, you'll see that there is a list of credible pharmacies and also providers that work with them. And it just shows you that you can go in or you can search for certain pharmacies, for example, but it shows you certain pharmacies that have experience compounding low-dose naltrexone, indicating that they're credible, and you want to choose a pharmacy that has experience compounding low-dose naltrexone appropriately. And then also the LDN book is a very small little book, but it's a really good overview about what LDN is and how for a lot of people this may be the last option, which hopefully we want to change that school of thought and have LDN not be a last resort, but it's a good overview of what LDN is, and it's a very quick read. All right, well, thank you guys so much. And if you have questions about LDN, please shoot me an email, call me. Of course, you can visit our website if you have more questions about anything else that Physician's Preference Pharmacy does. But I'd love to hear your questions about LDN, and especially if LDN is something that you're not currently incorporating into your practice. You want to know how to get started, you'd like some guidance in that, I'm here for you to walk through that process together and really help provide some additional options for your patients and help them get their health and wellness back on track. For a lot of people, LDN has been a saving grace and has been able to provide light at the end of the tunnel where otherwise they were not able to get it, and for a lot of people truly to get their life back. So I thank you so much for spending time with me today. And if you have questions, again, please shoot me an email or give me a call. I'd love to hear from you. I'll see you soon.